Thank you, Anand. It's always a pleasure to be back with the old gang. And this is a lot of work on atypical. I actually got an itch about looking at everything atypical in retina, actually. And we had several publications because of this itch. So we have some unusual things to say about macular diseases in the beginning. I have nothing, no financial interest in this presentation. All the studies which I have shown here are part of my work at Arvind Eye Care System, Madurai. So I'll, because of the limitations of time, I'll be considering only the four most common diseases where I've got most experience also. The central serous choroidal retinopathy, age-related macular degeneration, and two of my favorite topics, macular telangiectasia, and which I have stolen from Mahesh, external retinoschisis. Now, central serous retinopathy, I remember when I was a fellow, I had a student and he told me once very cockily that at least we can diagnose CSC very easily actually. And it's, I believe it's always an overstatement actually. Even a simple central serous retinopathy is not necessarily a simple diagnosis. Obviously, chronic CSR is a completely different ball game. And it can actually resemble all the diseases. I have seen them personally. Exudative AMD, exudative retinal detachment, chorioretinitis, non-AMD CNVMs, retinitis pigmentosa, and even acute CSME can actually mimic something like opertus maculopathy or even a tumor or neoplasia. Now, this is let's start at the base level. This is a simple case of subretinal fibrin and central serous choroiditis, but a lot of these patients get treated with steroids because they think it is choroiditis actually. Subretinal fibrin is a common presentation, more so if the patient is taking oral steroids by any route. So when a simple way to diagnose it to do a fluorescein angiography where you can find a point leak with the classic ink block pattern, and the simple treatment is, in this case, photodynamic therapy. This is a patient of subretinal fibrosis with exudative retinal detachment. So if you look at the picture on the left, it looks like a case of subretinal fibrosis uveitis syndrome, as Kalpana would probably agree. But when you do an angiography on this patient, you see that there are several point leaks. Thankfully, they are not the RP decomposition kind of pattern, which can be very confusing. But if the point leaks are there, I have personally treated a lot of these patients with simple laser treatment and they resolve. Now, angiography is not necessarily a help always. Sometimes the clinical picture is very obvious and angiography throws up something completely different. In this case, we are confused that we are dealing with a CNVM or a CSCR. Now, let's first guess the common sense. Why it can't be a CNVM? If you have a CNVM, then for a CNVM to have such a huge detachment, it should be massive. And typically, the serous detachments are a feature of occult CNVM. So you should have a massive occult CNVM to have a detachment of this kind. It's very small. There's something fishy. Here, OCT settled the issue. When we did the OCT in this case, we saw that there were some streaks of retina. The parts of sensory neural retina were attached to the guilty PED with the help of some fibrin. And this has been described actually previously by Japanese authors. So we saw a few more cases like this and we published our series in Eye. And it is, so when we treated this patient with transpupillary thermotherapy, before the leak got settled, it got converted into a classic ink blot. So basically it was a classic smokestack leak which was converted into this unusual CNVM kind of leak because of this adhesion of retina to the underlying PED. And by simple treatment, it first revealed its true nature before getting resolved. Now this is a flip side of this picture. You have a picture which looks like an acute CSC. Again, angiography shows something very unusual. You see some kind of fuzzy leak or ooze and you're not able to make up your mind. Now look at the disc. What is the comment on the disc? It looks fairly normal. I mean, I'm focusing your attention on it, but you can't see anything abnormal in this. Now look at this. Now when you have a picture like this, though there is a detachment, it is never a serous retinopathy. It is always a foveous crisis called by an optic pit, even if the pit is not visible. In fact, Spade first talked about such occult pits, and I've seen several cases which is under publication. So this is a case where we have an occult pit. See again, there is no pit visible, neither on clinical examination or angiography, but this thing is very typical. The schisis is very typical of the pit, and it is coming from the pit itself. You can see the pit on the OCT. So why we have to know that? Because here the treatment is surgery. No treatment, no laser, nothing will help in this patient. Now, sometimes a clinical picture itself is what the diagnosis. So, if we have this patient who was referred as a case of sector retinitis pigmentosa with classic bone spicule pigmentation. You can have bone spicule pigmentation when you have inferior detachments, and you can see that there are PEDs here actually. Similarly, this case was referred as a Stargardt disease, but again you can see the PEDs. So, seeing the PEDs enough and seeing the fellow eye is enough to confirm the diagnosis, so angiography definitely helps. Now, this is a step higher actually. Now, this picture was very peculiar. It was diagnosed by one of our fellows as a case of amelanotic melanoma. And it was actually, I can't give you the stereoscopic view, but it was looking huge. It was looking very big. And I've actually seen some cases, I think Dr. Kalpana will deal with them, case of posterior scleritis which look very similar. Nodal posterior scleritis. Now, this case, as it turned out, looked something very different. When you do angiography, it looked like a rip. But when you do an OCT, it didn't look like a rip at all. Actually, a rip should not have such a huge elevation. This is a pre-rip picture, if at all. So now what happened here? There was a denudation of the overlying RPE because of the chronicity of the PED. And we got it confirmed, and Anand saw another case which looked very similar, and again, similar experience and a similar PED. So we published in OSLI, and we learned a new lesson about the appearance of CSC. So what clinches the diagnosis? The patient age and sex is the age-old conventional teaching that when you get a serious detachment in a young patient, think of CSCR. When you get a serious in an old patient, think of AMD. I'll go and refute this wisdom in the next few slides. But this also holds ground in some cases. Then if the history is off and on, the patient reports recurrences, it is in favor of CSCR. Use of steroids, one must always ask actually. Nowadays they even associate this a lot with Viagra use. So, but use of steroids, like the patient is asthmatic, has arthritis or eczema, and using steroids for these reasons, then that's a very well known, but generally not asked about cause of CSCR. There's generally a lack of family history when you have those pictures of so-called Stargardts or HMD. Look at the fellow eye, and sometimes just a look at the inferior retina will suffice to make the diagnosis in a teardrop CSCR, as I showed before. The only investigation we are going to ever need is fluorescein angiography and OCT and a little bit of common sense. Now let's come to age-related macular degeneration. Now AMD, because simply what's very common, it is mimicked by a lot of diseases. And at all stages of AMD, you can have confusion. You can have a confusion at the stage of early AMD when you have only drusen, intermediate AMD when you have larger drusen and PEDs, geographic atrophy, or exudative AMD. And look at the differential diagnosis. Chronic CSC is the differential diagnosis in all these. So these two actually are quite a nuisance at a lot of cases. So mainly also because now we are seeing CSR in women also more frequently because they are becoming a lot more like men. Actually, there was a study in UK to show that the level of testosterone in women is rising actually. So, and that is related to their success in the academic fields. So this is a fact, and that's probably the reason why they are also getting CSC or the which was the domain of the males not long back. So this is a patient who looked on the clinic examination to have a lot of drusen, but was found to have a CSCR because you can see the soft leaks in fluorescein angiography. This is a patient who looked like, now this is something which will look fishy to any trained examiner, but it looks very symmetrical and bilateral. But here the key is looking at the family, which we all always miss. This case we actually published in Nature Genetics with the help of our colleagues in Iowa. But this is a patient of familial or dominant drusen. Family history was positive, it's a autosomal dominant disease. And we see the drusen extending radially also. There's generally a radial pattern, so they're also called radial drusen. The patients, you can see it in younger patients also. But the problem is, if the younger patient will also become old. So if you see that in older patient, that doesn't mean that it is presenting late. It is basically that you are seeing the late presentation of an early disease. Now this is a very interesting patient which looks a lot like intermediate AMD, right? Now when you do angiography, OCT, what does it look like? Initially you will think that it looks like a CSC, but if you look at the OCT clearly, it is not the serous retina which is elevated, it is part of the RPE also. So it's a classic OCT of Best disease. And there's another problem. If it is a young patient, then probably you will not think of AMD because it's a young patient, right? It's not age-related macular degeneration. But it's an old patient, we call it ABMD, right? Adult onset vitelliform dystrophy. And these cases many times have a normal EOG. So now that's a sticky problem. So you have to bank a lot on your training and this thing, and also on the family history. Now this is a patient where there is an extensive geographic atrophy. What made us think of something different is because the vision was very good. Now when you have such geographic atrophy, the vision should be miserable. But the vision was very good, and when we did the angiography, Anand, can you announce people to have put their phones in silent mode? So
phones kindly put it on silent mode.
We had diffuse retinal pigment epithelial decompensation and also with some foveal leaks, which made the diagnosis pretty easy. And as I said before, sometimes just looking at the lower fundus, we should make a habit of looking at the inferior fundus in all cases of serious detachment, and sometimes that settles all the problems. So you get a teardrop and then that settles it. So exudative AMD, this patient looks like in clinical examination. Fluorescein angiography looks like it's an occult AMD, but not really very convincing. Now this is again a picture of a serious detachment. Now this patient is probably a patient of a chronic CSCR because again the same logic. How much should be the size of an AMD to cause this much detachment? You don't see any AMD or any sub-RP lesion in the first place. To have an AMD cause a detachment should be generally occult. That means it should be below the RP. The RP is flat. So in differential diagnosis, the age may not always be helpful because now we are seeing CSC in old age and also in women. You have to correlate the clinical picture of the visual loss. For example, in that case of geographic atrophy, OCT and angiography again are helpful in most cases. Or simply a look in the retinal periphery and we can ask leading question about family history, drugs and systemic disease. Now I come to my favorite. Macular telangiectasia itself is a masquerader actually. Now this disease name itself is a misnomer because the commonest manifestation of macular telangiectasia is type 2 disease, and type 2 disease you never ever see clinical macular telangiectasia. Almost never. Right? Some people may say that in a very high resolution picture you can, but on a default examination you don't see them. So that's why it's called occult telangiectasia by gas. So it can look like AMD, CSC, hereditary macular degeneration, BRVO, radiation retinopathy, even cancer-induced tamoxifen retinopathy. So this is a case which looked like CSC or AMD, either of them. It was neither of them. Fluorescein angiography clearly showed that it was macular telangiectasia. You can see the capillaries in the early phase, and you can see the very classic leak in the late phase. This looked like mactel with a pigment epithelial plaque, the classic stellate plaque of the mactel. But here, again, the examination of the inferior fundus showed that it was a CSCR. Now, this is, in my experience, one of the commonest ways I've seen the mactel presenting as a bullseye maculopathy. In fact, a lot of these patients have even undergone an ERG. Now, this is one of the, again, you can see an RP depigmentation around, but you don't see any telangiectasia. Angiography is extremely typical in many of these cases, very simple to diagnose. There's one more diagnostic aid now, very beautiful, again OCT. You see that in spite of the gross leakage, they do not have leakage in most cases. In some cases you have, but it's rare. The default finding is foveal atrophy. So if you see atrophy instead of edema along with the leakage, then it's diagnosis of macular telangiectasia. Finally, I come to extreme retinoschisis. Again, a huge list of differential diagnoses like ROP, inverse macular dragging. Now, inverse macular dragging is something I did not know earlier actually. When you think of macular dragging, you classically think of FEVR or ROP. This is probably the only condition I know where you have a nasal dragging of the macula. And this was reported by Bill Testman actually in a brilliant work. It can develop a Coats disease, a resolved choroidititis. Now you think of a typical extreme retinoschisis, I think what I'm talking about. Is it Coats disease, choroidititis, is it possible? AMD, dominant drusen, Auger's disease, or settled RD. I'll show examples of all of them. So this case, if you look at the right eye, this patient, it looks like, it can be confused with the extreme ROP. But again, you can see this classic pattern actually, right? Of the blood vessels. This is not seen in ROP. This is very typical of extreme retinopathy. But again, the left picture does not show the left eye. It is not the same eye. It is, right? If you look at this picture, you are not looking at the left eye. It is again the right eye where there is a nasal dragging of the retina and the macula. So the macula is actually dragged nasally and it is sitting on the edge of the disc. And you can see this retinoschisis and vitreous veils, as you would call them. Very classic, but you don't see any typical macular schisis because it's extremely severe. And this can take this kind of form also. It can sometimes present with macular scar like this, or in both eyes, one of both eyes, where it becomes very difficult. Sometimes you have the peripheral exudation like this, but you have a classic scarce in the center. But in other cases, you might have a complete detachment, exactly like Coats disease. So what do? We found that sometimes simply the examination of the fellow eye is sufficient, as in this case, you can see a classic schisis. But most surprisingly, we found that even in these cases, if you do an OCT, you can find the typical splitting of retina on the top of this hump. So OCT in our cases, in our series, which we published in AGO in 2007, was confirmatory, but generally it's the ERG which is the definitive diagnostic aid. Obviously, you also have to look at the family, especially the maternal uncles and maternal cousins, and that confirmed diagnosis. This is a recent case we saw. This is a patient who was in his 50s, and we thought about early AMD, but again we got confused or a little put off by this vitreous floater kind of thing. So when we did an OCT, we found that the right eye was completely atrophic, so we couldn't make out anything, but the left eye was classic. Now I come to the autofluorescence, which is now the diagnostic aid in both macular telangiectasia and in extended cases. So here you see a central exaggeration of the hypofluorescence and a light halo, which indicates the progression of the disease. So this is a new landmark, and obviously the ERG is very typical, the negative ERG. So this is reported earlier by Sang et al., and we published a case report in IGN about this. So how do we diagnose a typical XLR? Typically the young male patients, but the old patients may not have foveal schisis. Look at the fellow eye, take a family history, examine the maternal uncle and nephews, and again OCT and ERG are diagnostic several times. So we have to take home summary, we have to look at the patient's age and correlate with the symptoms in the family history, take a detailed history, ask leading questions sometimes about the use of, for example, Viagra. Sometimes you have about systemic disease, malignancy, perinatal history. Investigate judicially. FFA and OCT suffice in most cases. Electrophysiological tests are rarely required. And do not jump to treatment without a diagnosis, because misdiagnosis can be fatal. Thank you very much.